I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Welcome, everyone, to the May 2016 PRS Journal Club podcast. I'm Amanda Silva, a fifth-year plastic surgery resident from the University of Chicago, and I'm joined by my fellow PRS resident ambassador, Sammy, Sinno, a fifth-year plastic surgery resident from NYU, and Raj Sawh-Martinez, a fifth-year plastic surgery resident from Yale. Today, we welcome our guest discussant, Dr. Heather Furnas, a plastic surgeon from Northern California who co-founded her practice, Plastic Surgery Associates, and is also an adjunct assistant professor at Stanford. We'll be discussing an article by Devulapalli et al. At Johns Hopkins entitled Primary versus Flap Closure of Perineal Defects Following Oncologic Resection, a Systematic Review and Meta-Analysis. So abdominal perineal resection and pelvic examination are radical surgeries. They are commonly used for locally advanced or recurrent pelvic malignancies. These surgeries have high morbidity rates due to high skin tension closure and large resultant pelvic dead space, which can lead to accumulation of fluid collections that are prone to infection. Infectious complication rates following APR have been cited to be as high as 66%, and flaps have been shown to drastically reduce that rate to around 16%. However, there still exists some uncertainty regarding their efficacy due to small study populations, significant heterogeneity amongst the studies, and varying availability and experience of the reconstructive surgeons at different institutions. In fact, there has been a previously published systematic review by Nassar et al. That included a greater number of studies than this study did, and they did not perform a meta-analysis due to the heterogeneity of the included studies. So the authors performed a systematic review and meta-analysis to determine the efficacy of flap reconstruction versus primary closure in APRs and pelvic examinations on reducing surgical site complications. They ultimately included 10 studies, 1 randomized controlled trial, and 9 retrospective reviews. This comprised 566 patients, 226 flaps, and 340 primary closures. 8 studies used the VRAM flap, which totaled to be around 86% of the patients, and 2 studies used Gracilis flaps, which was 14% of the patients. So they looked at perineal wound complications, both total, major, which they defined major as requiring an intervention, and minor, abdominal hernia rates of reoperation, and length of hospital stay. They found that primary closure was more than twice as likely to be associated with a total perineal wound complication compared to a flap closure, so that rate was 52% versus 35%. And they also showed that rates of major perineal wound complications were also significantly higher in the primary closure group at 25% versus 8%. They did not find any significant difference between the primary and flap closure for minor perineal wounds, though, at a rate around 25 to 22%. Abdominal hernias was the same in both groups, around 19%, and length of stay was about the same in both groups, 19 versus 16 days. As well, the reoperation rate didn't vary between the groups. It was around 15% in both groups. So I would just open up now a discussion to everyone, specifically, obviously, our guest discussant, Dr. Furnas. I'd be curious what your guys' experience is, especially at your institutions, if you're really involved in these cases, or if it tends to be high-risk patients that are referred to you, or what's kind of your experience?
Well, Amanda, I'm going to have to say I haven't had an experience like this in a long time since I'm an aesthetic plastic surgeon at this point in my career. But I love the article. I think they sort of took the challenge of wrestling an alligator to try and, come up with a moral of the story, distilling it down to essential oil. How are these perineal wounds treated? What's interesting is that the complication rate among the primary closure cases was so much higher than that with flap cases. You have a patient population where you've got this big empty space that's accumulating a lot of fluid, predisposing to infections. You have a high level of breakdown in the primary care wound patient population, which we would expect with almost 90% radiation. So the question is, why are so many patients being treated with primary closure? And I think one hint is that if you look at the references, out of 45 references, only 4 came from plastic surgery. The study didn't break down who the surgeons were who were actually doing the surgery, and so one could surmise that perhaps the patients aren't making it to plastic surgeons in the first place, and the perhaps non-plastic surgeons who aren't comfortable performing myocutaneous flaps are the ones doing the primary closure.
Mm-hmm.
That's a great point, Dr. Furnas, because it's sort of the analogous situation to abdominal wall reconstruction, where if you look at the literature, direct incisional hernia repair is often reported in the general surgery literature, but when it is sometimes less commonly reported with myofascial release or component separation, those outcomes are always better, and this is sort of the same thing. Obviously a flap is going to give you better closure of dead space, more robustness for tolerance of radiation. But you're right. I mean, that's a very astute observation that it's mostly not coming from the plastic surgery literature. So that's an interesting observation.
What I kind of thought might be the case with that, and I didn't look I'd be curious to look back and look in more detail, but I think some of those might have actually even been written by plastic surgeons, but purposely put in the general surgery literature in hopes that a general surgeon will read it and think, oh, I should.
Yeah, that's what we should do.
Yeah.
Yeah, the last, go ahead, Raj.
No, I was just gonna, simply say, I think the big points for me too. I think meta-analyses are always very tough, and I think this is actually a very interesting meta-analysis. You can do them very poorly in the sense that it's hard to control for studies that are really equivalent or similar. And even this one, obviously, there are some, and they make the point in their limitation sections that there are certain, characteristics from the different studies that are different. So sometimes you're really comparing apples to oranges. Oftentimes, I find, at least in meta-analyses. But I think here they're really focused in and honed in on trying to really be very specific about the questions they were asking. And Amanda, I think your question about our experience, I think anecdotally, because certainly I haven't done any major studies of this, it seems to me that it's not. The times when linear closure go well or they don't really end up having to seemingly to have to do with what Dr. Furnas was saying about the radiation history and the patient sort of milieu that's in the setting of what these wounds are. If you have a patient that does not need radiation and doesn't undergo those, then maybe you could just do linear closure, and maybe you don't need flaps in those cases. Vice versa, is the fluid enough to cause that, and would we see a decrease anyway? That would have to be teased out. But I think when the comorbidities are greater and we're putting the patients through, whether it be chemo or radiation, I think those factors, would be bigger deal than just whether or not it's a linear or a flap closure, but that's purely anecdotal.
Yeah. And I think that's something that they pointed out in the article, that we don't know who the high-risk populations necessarily are yet, and that would be an area for their study to know, rather than just refer all patients who need a pelvic stent or an APR to a plastic surgeon, maybe have it be more select. But since we don't have that data, maybe it is best to just involve a plastic surgeon to take a look and be available if, when they're going to close, the tissue looks woody, it doesn't look good, it doesn't seem like it's going to come together without tension. I don't know. We sometimes are involved in these cases, but I feel like it's not necessarily 100% of the time. It's kind of rare. And sometimes we get called after it's fallen apart to then come and do the flap.
Same.
Yeah, it would be interesting to see if everyone did see a plastic surgeon, would plastic surgeons find a subgroup that would be amenable to primary closure? The author suggested looking at wound size, and in the data that they had, there wasn't enough information about comorbidities, and that would also be very interesting to look at. One thing that would also be interesting is the long-term survivability. With the primary closure complication rate being so high, does that compromise the survivability of the patient?
Well, definitely, we can all agree this is a very well-done systematic review on a topic that hasn't been meta-analyzed before, and they actually, in terms of performing the meta-analysis, did a very excellent job in looking at all the studies and coming to the conclusion that they did.
So I agree. Amanda, what would you say is your 20-second takeaway from this article?
So my takeaway is that flaps for pelvic viscera resections would decrease wound complications, and they don't put a significant increase in donor site morbidity or a negative effect on hospital stay or reoperation rate, and that we should encourage our general surgeons to send the patients to us more often, and we need to further define which patients are the proper candidates for prophylactic flaps.
Excellent. How about you, Raj?
Sure. I think my takeaway with this from this study would really be, that when needed, microcutaneous flaps reduce complication rates tremendously over inline closure, and that's been demonstrated in this meta-analysis through a series of multiple studies. And the next big outlying question will be, what are those? Can we identify those groups of patients that really can benefit from microcutaneous flaps right away? How can we better study them, and how can we better provide that care to our patients a priori in a really targeted way?
Terrific. And how about you, Sammy? What's your 20-second takeaway?
That this study is a high level of evidence study showing that for major pelvic wounds that flaps are the gold standard. Great.
That sounds like a plastic surgeon's excellent point.
Hashtag call plastics.
Yeah.
Exactly.
Great.
All right.
Well, thank you so much, Dr. Furnas. We'll go ahead and wrap up this section of the Plastic Surgery May Journal Club. Thanks, everyone, for joining in.
Thank you so much.
Thank you.